Greetings and welcome to another lecture in psychopathology. This particular lecture deals with what I'd like to call the big kahuna, and that would be schizophrenia. Schizophrenia has been a major disorder since before, of course, the beginning of psychology. And it is a disorder that seems to be present in all cultures, more about that later, and it generally is considered, and usually is, a very serious disorder. Now, schizophrenia is the current term for what used to be called psychosis. Now, I think I've mentioned before a couple times that disorders used to be divided up into neuroses and psychoses, with neuroses being the more mild disorders and psychoses being the more serious ones. Well, psychoses here, and particularly with schizophrenia, it's considered a loss of contact with reality. And this loss of contact is fairly serious, not only in terms of thinking things, but also perceiving things. It's usually pretty darn serious. Now, schizophrenia literally means split mind. And this is probably where at least some of the confusion comes between schizophrenia and dissociative identity disorder, which used to be called multiple personality disorder. It isn't a split between personalities, although sometimes in schizophrenia it can look like that. People might show very serious differences in behavior between times. But it's considered a split between the mind and reality. That is where the split is. Not between personalities, but where the person just does not know what reality is. They simply don't know. The prevalence is about 7%, somewhere between 7% and 1%, depending on how precise you want to be and where you are. There's not a whole lot of difference between cultures. This appears to be one of those disorders that doesn't necessarily have a big psychological or cultural proponent to it, part of it, in that it seems to be really pretty much biological. And being biological and also being pretty genetic. But the only disorder that appears to be more genetic is bipolar disorder, other than, of course, something like Huntington's that's 100% genetic. But it's a pretty constant. Men tend to get it younger. Men tend to come down with schizophrenia usually in late adolescence and early adulthood. We're talking late teens to early to mid-20s. Women tend to come down with this disorder more late 20s, early 30s. So it's a little bit later for women. We're not sure why. There are some suggestions that we'll get to, but women tend to get it a little later. Men also tend to have it worse. When men develop schizophrenia, the symptoms tend to be more extreme. What are the symptoms? They're a grab bag. This is one disorder that I really think if it had been diagnosed today, it would actually be multiple disorders. It wouldn't just necessarily be one, because there's all sorts of things that go along with it. We have delusions. We have thought processes that are not rooted in reality, that are obviously wrong, can be proven wrong, yet people continue to believe them. We have hallucinations, which are perceptions that are incorrect, perceptions that do not exist in the general reality. Disorganized speech and behavior. People with schizophrenia may speak in what's called a word salad, in much the same way that a garden salad is a bunch of vegetables all sort of mixed together. A word salad is a bunch of words all sort of mixed together. And in fact, they might not make a whole lot of sense. Behavior can also be disorganized. People can do behaviors that don't relate to one another when they're doing a task that may have nothing to do with getting the task done. It's thought actually that this disorganized speech and behavior may be a reflection of disorganized thought processes. That the person is simply having problems keeping what we would consider a linear, quote-unquote, normal train of thought, and that their speech and behavior may reflect this. We can also see emotional abnormalities, incorrect emotions, too much emotion, not enough emotion. Now, oftentimes these symptoms are divided up into positive symptoms versus negative symptoms. Positive versus negative. Positive symptoms are generally when you have too much of something. You have too much emotion, you have too much movement, you have too much perception, you have too much thought. Or positive symptoms also include when things are wrong. You have too much of something or it's wrong. Wrong behavior, wrong thought, wrong emotion, wrong perception. On the other hand, negative symptoms are essentially too little of something. If positive symptoms are too much of something, then it kind of makes sense that negative symptoms are too little of something. Not enough emotion, not enough thought, not enough behavior. So if you think about it, these are also named exactly what they are. Positive symptoms is too much, negative symptoms is too little. Now, sometimes it can be difficult to tell, for instance, a negative symptom of not enough emotion from what's called a blunted affect. Now, affect means emotion, and a blunted affect may mean that people may feel the emotions, but they're not showing it. And this goes into the reality that, in fact, while it looks like you would only have positive symptoms or negative symptoms, you can indeed have both at the same time. Generally, there's a predominance of one or the other, but pretty much you can show both of these at the same time for a person with schizophrenia. Now, schizophrenia is not the only psychotic disorder. That's why the chapter heading is Schizophrenia and Other Psychotic Disorders. We already talked about a couple of personality disorders that kind of look a little bit like schizophrenia, specifically schizotypal. But there are also other disorders that are considered full-blown psychotic disorders and not just personality disorders that can look like schizophrenia and are indeed involved in the psychotic disorders themselves. The first is schizoaffective. Now again, this is named exactly what it is. We have the schizo part, which basically means the split. And then we have affective. Remember, I just said affect means emotion. So schizoaffective disorder is when a person has features of both schizophrenia and severe mood disorder. So they have the hallucinations, the delusions, the lack of emotion, whatever, but they also have severe unipolar or bipolar disorder. It can be either. So it's almost like a 2-in-1. It's very much a combination of the two. It's a mix of the two. And perhaps going along with the mix of the two thing, a person with schizoaffective disorder, their long-term outlook is better than schizophrenia alone, but it's worse than mood disorder alone. So it really does look like an actual mix between the two. Whether or not it's that, of course, we don't know. That's certainly what it looks like. Whether or not that's what it is up for some conjecture. But it may well be, considering this. There's also schizophreniform disorder. Schizophreniform. Be glad you don't have to say these. You just have to recognize these. What this is essentially is short-term schizophrenia. Okay? Normally with schizophrenia, the symptoms need to last for a rather considerable amount of time for a person to be diagnosed with full-blown schizophrenia. And in fact, very often the symptoms of schizophrenia stick around for quite a while, whether they are treated or whether they are untreated. At least the underlying symptoms do. So if a person winds up with symptoms of schizophrenia for like a month or so, they may be diagnosed with, preliminary schizophreniform disorder or preliminary schizophrenia. The symptoms themselves need to stick around longer before doctors can be sure that there is a full-blown schizophrenia going on here, as opposed to schizophreniform. Only the difference is how long they last. There's also delusional disorder. As I talked about before, delusions are a symptom of schizophrenia, usually among many symptoms. But in delusional disorder, the only symptoms are delusions. They don't have hallucinations. They don't have inappropriate behavior, unless, of course, you consider behavior appropriate to their delusion inappropriate, which it isn't. They don't have the negative symptoms. They just simply have delusions, very strong delusions. Other than that, they behave perfectly normally. That's delusion disorder. Remember, these things are pretty much named exactly what they are, which lead us up to the last psychotic disorder, brief psychotic disorder, which is a very, very short-term schizophrenia. If schizophrenia is when you have symptoms longer than 6 months, at least officially, and schizophreniform disorder is when you have symptoms between 1 and 6 months, brief psychotic disorder is when you have symptoms for a couple of days. And then they're gone. very, very brief. Very, very short. Okay. So, we got the various disorders and what's involved in them. So the next thing they're going to look at is possible causes, possible factors. We don't like to use causes. Possible influencing factors of schizophrenia. Now, this is in your textbook. I believe it is anyway. And if it isn't, I apologize. I'm pretty sure it is. But what this is basically is a risk of developing schizophrenia according to how related you are to your family. And in fact, even if this isn't in the book, it should be fairly easy to figure out. The more closely related you are to someone who has schizophrenia, the higher your chance of developing schizophrenia yourself. Okay? You're more closely related to your aunts and uncles than your first cousins. You're more closely related to your nieces and nephews than first cousins. And while aunts and uncles, if your aunt or uncle has schizophrenia, you're a little more likely than if your first cousin. If your nephews and nieces, then you're perhaps much more likely. Maybe that has to do with the environment. After all, nephews and nieces, they're a bit younger than you, but they probably grow up in a similar, perhaps, than aunt and uncle. Grandchildren, again, the same relatedness. But grandchildren probably share your environment a little bit more, or they certainly share your children's environment. Half-siblings, you may only have 25% of their genes, but very often you share the exact same environment, and you certainly share one parent. With full siblings, you share half of your genes with them, but you share all of your environment. With children, again, half, but you share even more of an environment. Fraternal twins genetically are the same relatedness as your siblings, but fraternal twins share a lot more environment than siblings do. They share a prenatal environment, they share a postnatal environment. They're the same age. So it makes sense that if a fraternal twin is developed with schizophrenia, that the other twin has a much higher rate than just for siblings. But the big deal, of course, is identical twins. With identical twins, it goes all the way up to almost 50%. Notice it does not go to 100%. And that is because schizophrenia may well have a genetic predisposition to it, perhaps. We think that it's one of those diathesis stress, that you may be born with a vulnerability that stress brings out. The vulnerability may be genetic, but the stress is environmental. And the more environment that you share with that individual, the more likely it is that if that individual develops schizophrenia, that you will as well. So even with 100% genetic relatedness, even with sharing all of their genes, or close enough to make no never mind, then it's still only about a 50%, because the rest of that is environment. The rest of that is the stressors. The rest of that is what the person lives with. And even identical twins do not share the exact same environment. Very often, even with identical twins, one twin is considered older than the other. The twin was born first, so they're older. Or one twin may be male and the other female. Or, I guess not with identical twins, sorry. But, the identical twins still aren't related exactly. That would be more fraternal twins. Might be some of the difference there. It would be interesting to look at fraternal twins of the same sex versus fraternal twins of the opposite sex. But with identical, there is still a different environment. Slight though it may be. And so we can't just say, well, it's genetic. If you inherit the gene, you're doomed, like we can with something like Huntington's. It's also the environment that plays a role, which quite frankly is true for virtually all of these disorders.